Welcome to the Open to Hope Show. I'm your host, Dr. Gloria Horsley, with my daughter and co-host,
Dr. Heidi Horsley.
This show is brought to you by the Open to Hope Foundation, as well as in partnership with the Compassionate Friends. Well, Heidi, I'm so excited about this show today because I love research. It's kind of amazing that we're going to have some research on grief and loss because, there's not a whole lot, and particularly the kind of research, the neurological things, and they're doing scans and things now. So really cool because we're going to talk about a bit about what makes individuals grieve differently and some thoughts that our researcher has on that. So Heidi, you want to introduce her? I know she's a friend of yours and a colleague.
Well, yes, we first both met MaryFrances, knew about her when she was a professor at UCLA, and now she's at University of Arizona, and we have recently reconnected. And like you said, Mom, I love the fact that she is doing evidence-based research and that she is doing real research on the topic of grief and loss. So she can shed some light on a lot of things that are going on right now in our bodies and in our brains as we grieve. So let me introduce her, and then we'll get started on the show. Dr. MaryFrances OConnor is a psychologist at the University of Arizona. She studies the physiological correlates of the wide range of emotional responses during bereavement. She has investigated the failure to adapt following the death of a loved one, termed complicated grief, and the neurobiological, immune, and autonomic parameters that vary between individual grief responses. Welcome to the show, MaryFrances.
It's so lovely to be here.
Really great to have you on. As I said, I'm excited about it.
Years
ago, how many years has it been since your brother died, Heidi? 35 years ago. Okay. I was teaching at the University of Rochester School of Nursing. And do you know who George Engel is?
Mm-hmm. Sure.
Yeah, the biopsychosocial model guy. Well, I was actually had the privilege of being on his team where we went around the hospital and talked to patients and families and that kind of thing. There was a psychiatrist, a psychologist, and nursing. And he's the first person who ever connected up in research the fact that there was an emotional connection with grief and loss, which I thought was really, really interesting. But when my son was killed, I wanted him to videotape because we did a lot of videotaping at the Marriage and Family Center. I wanted him to videotape us, my husband and I, and my cousin and her husband, because we all had the same loss at the same time. It was sudden. And I wanted them to do blood tests and urine tests and all that. And I couldn't get anybody to do it. They thought I was crazy.
Yeah. You were before your time, that's why.
And now we'd be trying to recruit you into
one of the reasons that I was interested is because I had talked to my cousin. We were very close. We would talk about what was happening to us physiologically, and we all lost 5 pounds in the first 4 days.
And what MaryFrances needs to know is that my brother and cousin died together in the same accident, and they were both 17. Yeah. So it is interesting, my Aunt Belle and my mom, having both lost their sons at the same moment, same age and same place, it could have been a very interesting research study.
Yeah, absolutely. And obviously there are such individual reactions to loss. Mm-hmm. But, in part in science, what we're doing is looking for patterns, right? What could be something, or what helps to explain some of the differences.
So talk to us about your research, because I'm excited that you are actually studying this field with neuroimaging.
Yeah. So, my research, people don't realize that, from here up is sort of one field and from here down is a different field, which I don't really see it that way. So I use, methods from both neuroimaging or neuroscience and also from autonomic and immune or cardiovascular, might sound easier to people, cardiovascular and immune systems. And I think they are obviously interrelated. But the reason, initially what really struck me was finding out that this phenomenon we sometimes call the broken heart phenomenon, where when someone loses a loved one, their own risk for mortality or for developing a disease or a disorder goes way up. So for example, in men, the chances of having a heart attack in the first 6 months after they lose their wife goes up so it's twice as high as the men who are married, their counterparts who are married. And so for me, I thought, well, if you take this supposedly sort of psychological event, finding out that this person who you deeply love is not around anymore and isn't coming back, if that can have a consequence like mortality, it seems pretty clear to me there's something physiological going on, maybe not for everyone, but could we find out more about that by doing some really specific and detailed research? And sure enough, over time, I think more and more researchers have become interested in it, and some of the work that I've done suggested there are things we can look at and there are changes that we can see.
Mm-hmm. Yeah, I know one of the things that I was talking to Heidi about, I was fascinated that you wrote the article about the fact that there can be actually a reward system in the brain for re-experiencing the loss. The brain can actually reward that.
Yeah, so it's always a little complex, and this is a single study, so there's probably about 5 or 6 neuroimaging studies on grief now, so that in science we don't actually consider that to be a very large number. That's ultimately we need to figure out what is the preponderance of evidence, what can you sort of look across studies and see. But in that particular study, something that we see is that we find our loved ones very rewarding. It turns out this is not even just at the level of enjoying them, which is sort of typically how we think about the word reward, but meaning that we want to return to them over and over and over again. And we believe that, even sort of bringing them to mind helps us in stressful situations, sometimes helps us release endorphins, things like that. And so what happens then when our brain is trying to make sense of the idea that this person isn't coming back, which feels quite foreign, the brain is all set up on prediction, and it has been predicting that that person will be there day after day after day. So as the brain is trying to make sense of this idea that they may not be coming back as you're adjusting, for a long time, it seems that we're still getting a signal in the brain that says, when I think about my loved one, I feel not pleasure, but reward, in the sense of I feel like I want to do this again and again. I want to think about them. I want to look for them. I want to bring out things that remind me of them. And over time, of course, eventually the brain works out, when I bring out photographs of them, it doesn't really mean they're coming back. I can still enjoy the pictures, but it doesn't predict that I will get to be with them again. And so what we were seeing in the brain is that folks who have something, what we call complicated grief, or the idea that a very small proportion of people develop a disorder after losing a loved one, that those individuals were still getting this cue from the brain as though they hadn't fully adapted to the idea that they weren't coming back.
Talk about a little bit about complicated grief, because I know there's a big thing about it, because all grief is complicated, people say. And one of the things that I think is kind of interesting is that there hasn't been, I think, enough connection between post-traumatic stress syndrome and grief. There just has been too much of a separation.
Sure. So what we know about complicated grief, and that's the term I use, although as we've been trying to figure out exactly what we would call this and what would be criteria, like you have criteria for depression to say, yes, there are people who feel depressed or feel sad, but that's not the same as having depression. So as we've been trying to figure out as researchers and clinicians, what would these criteria be? What would this look like? We've come up with a few different terms in the field, and unfortunately that's made things a little confusing for people who are trying to understand what we're doing. This is not uncommon at the beginning of a process. And so for me, the reason I like the word complicated grief isn't because, every grief, not every grief, most people's response to grief is distress, right? I mean, this is generally a truly awful thing that has happened. But what I like to think of is most of us have an inner resilience that we are able over enough time and with the support of loved ones and taking other ways of understanding what's happening to us, most of us do adapt over time and integrate the fact that this person has lived and meant something to us and is gone. We integrate that into our lives. But there are some people, and I think of this as, when you break a bone, you're going to heal it, right? And years later, if you look at an x-ray, you can still tell that that bone was broken. There is no going back to before the bone was broken. But what can also happen is you can get complications in that healing. So you might get an infection, or you might have a second trauma to, say, your leg, and that could prevent the bone from healing the way it would in someone else in a more resilient way. And so that's what I think of as complicated grief. Not that there's some weird other people out there that have this, but rather the normal process is going on, and there are these complications that are getting in the way of them being able to integrate it. So that's how I think about it.
Yeah, I see some of the problems with people integrating it have been things like other illnesses or other people being sick, or maybe you're in a court case.
Yeah.
Those kinds of things I've seen delay, there's a delay. But if I'm listening to this and I'm saying to myself, you know what, I think maybe my reward center is getting activated. What can I do to cool it?
So I would also just clarify the difference between, so I couldn't tell you, for example, if my insulin level went up right now, right? And so the reward system in the brain, although it sounds like what I'm saying is pleasure, that's not really what I mean. So none of us would be able to intuit if our reward center was active necessarily. So I just make the distinction in terms of, I think people are able to intuit, do I feel like I'm adapting? Do I feel like I have a better sense of what's going on than I did a few months ago? We have a lot of expectations in our culture about how much and when, and those, we don't know that those always map on to people's experience. But if you're comparing your experience to what you expect to be happening, even a mismatch can feel really difficult. Well, this is happening more or less than I wish it would, and also than it should be. But in any case, so, fortunately, we are able to distinguish in clinical psychology, we are able to distinguish the difference between, say, major depressive disorder, post-traumatic stress disorder, and complicated grief. Using the criteria, we find that sometimes they're comorbid. So you can have, just like you could have depression and anxiety, you could have depression and complicated grief, or PTSD and complicated grief. So we are able to tell the difference. They don't always go together, but of course they can go together. So, it just, struck me because of what you were saying about PTSD, for example.
MaryFrances, when in looking at complicated grief,
do
you find a correlation with the way that somebody died and with the relationship that they had with the person that's living?
It's an excellent question. Of course, as soon as we figure out, if we can identify these people sort of reliably, or identify the patterns that are looking like a trajectory of less adaptation, of course, then we want to know, could we predict this so that we could try to, intervene sooner or help to monitor folks if that was useful to them. And we have a few predictors. So it turns out that an unexpected death, which can be the same or different as a violent death, but can also be the same or different as a sudden death, right? So you can have a death that isn't sudden, that still feels unexpected, right? In any case, those types of predictors do often seem related to distress early on. So when we're not prepared for something early on, it's quite distressing if we didn't know it was going to happen. But it turns out that, for example, in the DSM-5, where we find the complicated grief, they call it something else, where we find that diagnosis under further research, they actually suggest that we wouldn't start looking at this for a year. So as we get later into the process of adapting, it seems the unexpected nature of it becomes less important. Over time, we our brain probably gets used to the idea that it's happening, and so that part matters a little bit less. But like you said, one of the things that does seem to be predictive is something that we sometimes call anxious attachment. So folks who have had early life experiences that were related to their having difficulty bonding, say, with their parents. So for example, someone who lost a parent when they were a child, obviously there was a disruption in that attachment system even early on. Or children that had a lot of separation anxiety, you know, when they first went to school, say, for example. It seems that those types of experiences are sometimes predictive of having complicated grief when, as an adult, you also have a death that happens.
Do people that have buried children, that have lost children, are they maybe at higher risk for this than other groups because it's so out of the life trajectory and life experience to have a child die before you do?
Yeah, so I would say that, the research suggests, and of course, early days still, but the research suggests that the death of a child and the death of a spouse do lead to higher rates of complicated grief than some of the other types of losses, death of a parent, death of a grandparent, although there's then individual difference of what that individual means to you, regardless of the relationship. But just to be clear, even if, so we typically think, when we do meta-analyses where we look across a bunch of research studies, we find the rates of complicated grief to be about 10% of people who lose a loved one. So if you think of it differently, 9 out of the 10 people you meet who have lost a loved one will not develop complicated grief. Now, with the death of a child, we've seen rates somewhat frequently, even as high as 25%. Of people who've lost a child. But it's still just helpful to remember that means that 75% of people, even who lose a child, which is so distressing, don't necessarily develop the disorder of complicated grief.
Well, that's great information. Now, I know you're involved with research. Are you doing private practice? And what if I think after listening to this that I might have some complicated grief or I want to know more about it, what would you suggest I do?
Regardless of how one feels that they're adapting, one thing I think that my research into the physiology has really brought home for me is that, often when there's a caregiving period shortly before someone dies, or sometimes for a long time before someone dies, often the caregiver, who then of course eventually is the bereaved person, that person often hasn't had a lot of time to focus on their own health, their own physical health. And so knowing these increased rates of physical mortality and morbidity, as we would call it, so having the development of physical diseases, one of the things that I think is really important when people are grieving is to go and get your regular annual checkup, right? Go to your dentist in a way that you would normally, but now is a good time to check in and see how your health is doing. Because it turns out, of course, that let's say you develop hypertension or blood pressure problems, just as you were saying, all of that adrenaline that's running through your body dealing with this stress. If you go to your regular physician, they can detect whether you have hypertension, whether or not you're bereaved, right? And so it's just good to get the health checkup regardless, and then to use whatever treatments that doctor is suggesting, regardless of what preceded the high blood pressure.
They may also need to go and see a therapist and speak to them about what's going on, especially if they feel like they're very stressed out and they're worried that they don't feel supported, and they could go and see somebody, a therapist basically, that specializes in grief and loss.
And I would suggest that you find a therapist who knows something about grief and loss and shop around.
Yeah.
If somebody doesn't work for you, shop around, Hyde, right?
Absolutely. I always say that. I honestly believe that the first session with a therapist should be to see if they are a good fit. I mean, that you should really be asking them questions and seeing how you feel and checking in with yourself, because if it's not a good fit, you need to go to somebody else at that point, rather than just saying, okay, therapy's not for me. The Compassionate Friends, it is the largest peer-to-peer organization in the world, and you can go online and join chat rooms and get support 24/7 through Facebook. And I think that's really important for bereaved parents and bereaved siblings and bereaved grandparents. And I love everything we've learned today, because I think it's really helpful for people that have had death, because I think one of our biggest fears is that we're going to have complicated grief, or we're going to be pathological, or all these other things. And I think you're kind of normalizing a lot of things and saying, look, yes, complicated grief does happen, but it's relatively rare. You know, it's a 10%.
Absolutely. And, you know, even having even if you end up, you know, finding out or discovering that you yourself are suffering from complicated grief, there's interventions. It's not an end of the road kind of thing. It means that now we have a specific way of thinking about the particular complications in your healing. And we can, just like you can give antibiotics when you're, you know, dealing with a broken leg, we can deal psychologically, like you were saying, with how to address those symptoms that you're having, and get back on the healing path.
Absolutely. I love that, MaryFrances, and I work with Catherine Shear at Columbia, and she's wonderful, and I love the protocol and the treatment regime she set up, and I know that you have published with her. So yes, I totally agree with you. Like you said, knowing that you have complicated grief is not the end, it's the beginning.
And I want to thank everybody for watching this show today. And I hope that if you are feeling alone and lost, that you will visit us at opentohope.com, and that you will tell everybody about our shows. And we have radio shows, television shows, thousands of articles, all tagged for content, so you can look at your type of loss. Thanks for watching this show today. And Heidi and I always want to remind you that if you've lost hope, please lean on ours until you find your own, and God bless.